So welcome to our final, I think, Women on Wednesdays. We may be doing one more just to sort of do a wrap up of the legislative session, which is ending soon. I'm really excited to have our guest for today. Nicole Deggins is a friend of mine. We met doing a leadership development program called Hive. And so we've known each other for a couple of years now. I'm just going to talk a little bit about her because she's pretty much the go-to expert on the subject of birth work and birth justice, at least in my opinion. She is, a much sought after trainer, public speaker, community educator. She's been working to eliminate perinatal disparities and to bring more transparency around prenatal education and equitable birth. Not just in Louisiana, but she's worked all across the country. So in addition to the trainings that she does and the community work, she's also on the Louisiana Pregnancy Associated Mortality Review Committee and the Louisiana Healthy Moms, Healthy Babies Council. She's a faculty member of the Louisiana Perinatal Quality Collaborative and is an active consultant for Global Infant Safe Sleep Center. So Nicole knows her stuff. I'm very excited to have her here today to talk about maternal health and the policies that we need in Louisiana to change our maternal mortality crisis. So with that, I'm going to turn it over. I'm going to stop sharing my screen.
Okay, so then I can share mine.
That's it.
It says host disabled participant screen sharing.
Did I? Let's see.
Yeah, you can change it though, right there. All the Zoom.
Okay, I think I made you a co-host, so you should be able to do that now.
Yep, there we go. Thank you. Thank you, Michelle.
All right,
All right, let's see. We're going to do that. Yes, cool. So here we go. So I do have a PowerPoint. I do have to apologize. I'm running a little frantic. The past 24 hours has been a lot for me in a lot of ways. This work that I do is super, super heavy. And then living as a Black woman in America sometimes can become heavy. And so recently things have been heavy. So I feel these things when my community is murdered and damaged. I feel these things. Not just in birth work, but in all sorts of social justice work. So I just want to give you that so that you know that that's how I'm feeling today. And I just felt like I needed to name that. So it's often said that the way a nation treats its women and children determines the way that that nation will go. Somebody's trying to get in the meeting. I'm going to admit them. I admitted her. Okay, so anyway, worldwide, we know that infant and maternal health are used as measures of the health of a nation, and across the United States, maternal child health is a marker for the health of a state. That said, it is important that we understand, that we know, and that we fully internalize the fact that the health of women matters. It matters not just for women, though. It matters for everyone. It matters for men, it matters for children, it matters for our government, it matters for our economy, it matters. A wise man once said, a nation can rise no higher than its women. It has also been said that when you heal a woman, you heal a nation. So when we think about this, and we think about Louisiana, how does this translate? How do we treat our women and families? Unfortunately, our birth outcomes tell us that we don't treat them too well. On every marker for maternal and infant health, the state of Louisiana has some of the worst outcomes in the country. So let's take a quick look at some of the actual numbers. Preterm birth is the birth of an infant before 37 weeks. Every year, the March of Dimes compiles data on the preterm rates across the country, and they give states a grade based on their percentage of preterm births. So once again, as every year, the Louisiana has the dubious distinction of being under of a few states who have received an F. 13% of our babies are born premature. This is nearly 8,000 babies a year born prematurely across our state. An infant is considered low birth weight if they're born weighing less than 2,500 grams. Approximately 70% of the babies who are born low birth weight were also born prematurely. So this 13% of the babies, these 13% who are born prematurely are more likely to be born low birth weight. And right now, greater than 10% of our babies are born low birth weight. And currently we have the second highest rate of low birth weight babies in the country. These infants, their families, our medical system, and our state definitely suffer as a result. One of the things that I think is really horrific when we even look at just these two statistics to start out is that things have not changed or improved at all over the past 10 years. So we look from 2008 to 2018, this is preterm birth. There's no difference. We have been in the same space year after year after year. If we look at low birth weight, we again see the same thing. So is it that we don't have the resources, the time, the energy, or is it that we just don't care? Part of me says that we just don't care. And when I say we, I don't mean me. I mean that there is a collective we across the state of Louisiana that does not care about the health of women and babies, because if it did, this would not be the case. 10 years, we have no differences, no changes. We can see here, this is like a distribution map across the state where we can see the red states or the red parishes have the highest rates of the preterm birth, and low birth weight is here, where the darker green are the parishes with the worst outcomes. I like to point out here, like this is, you know, we have these little pockets of spaces where there is green, which is not even good. Even the green is not good, but it's better than where we see the red. So infants who are born premature and low birth weight, they are more likely to be at increased risk. They're more likely to die before reaching their first birthday, more likely to have a case of infant mortality. Per the most recent CDC data, the state of Louisiana has the infant mortality rate of 7.6 per 1,000 births. This makes us the state with the second highest infant mortality rate in the country, and it means that nearly 500 newborns in our communities are gone. Their families suffer, their families don't get to celebrate them, and it's really unacceptable. So, you know, it's really clear from our statistics and our national standings that we have a lot of work to do around infant health. And unfortunately, this data that I've given you only scratches the surface, because in addition to these statistics, we have unacceptable health inequities and health disparities. In every one of these areas, infant mortality, preterm birth, and low birth weight across the state, there are clear racial disparities, where Black women and their infants are at increased risk for poor outcomes. When we look at preterm birth, we see that the preterm birth rate for Black infants is 16%, which is 52% higher than the rate among other women in our state. Low birth weight, twice as likely to be born low birth weight. And then if we look at the infant mortality, Hispanic infants have an infant mortality rate of 6.3. Caucasian infants have an infant mortality rate of 4.8, so that's below 5. All the while, the infant mortality for Black infants is 10.5 per 1,000 births, greater than twice as likely as Caucasian babies across the state. So unfortunately, when we talk about maternal and child and infant health, I often feel like I'm the bearer of bad news, right? It's just like bad news after bad news after bad news. And unfortunately, that is the reality. And I believe until we understand what's wrong and how we got here, we really can't work to fix the problem. So according to the World Health Organization, maternal mortality is the death of a woman during pregnancy, birth, or within 42 days of giving birth. Between 2011 and 2016, the state of Louisiana confirmed 47 deaths that they definitively classified as pregnancy-related mortality, meaning that the death of that woman was somehow connected to her pregnancy, whether it was a pre-existing condition that was exacerbated by her pregnancy, or something that happened during the labor and delivery pregnancy and birth process. It's important to point out, a lot of people are hearing about maternal mortality and you know, understanding that there is a crisis around maternal mortality, but it's also important to point out that for every woman who dies, 70 women suffer. So we're talking about 50,000 women a year across our country. I didn't do the math, 47 times 70 across our state. And these are women who ended up in the ICU, ended up with an emergency hysterectomy, ended up with a colostomy bag when they went home, kidney failure, strokes, brain damage, all of these things connected. Some of them chronic disease progressions because of the way that they were cared for, or rather not cared for well. Some of them things directly connected to the pregnancy and birth, a botched cesarean section that became severely infected. So all of these different things are happening. We also have to know that this does not account for the countless women and families who suffer traumatic birth experiences. Right now, the numbers of women who say that they had a traumatic birth experience, I'm talking PTSD traumatic, depending on the research source, will give you up to 40%. This also does not account for the families, the sisters, the brothers, the doulas, the birth workers who are secondarily traumatized, who experience secondary trauma from these experiences, and who have lost their loved ones, lost their sisters, and also experienced secondary trauma watching the trauma happen to their loved ones. So there are thousands and really millions and millions of people across our country suffering, and across our state, thousands of people suffering as a result of maternal mortality and morbidity. Now here we can see the numbers of maternal mortality across our state. Louisiana, here it says we have a maternal mortality rate of 12.4 per 100,000. I'm gonna talk about that in a hot second, but just know that this number is an underestimate. When we look at these results from this particular report, which looked at numbers from 2011 to 2016, remember that this report only counted women who died up to 42 days after birth. At that time, we look at Region 5. Region 5 had the highest maternal mortality rate, but then we can also see that we can look at, like, as an example, Region 1 had 10 people. Right? So there are 10 women who died here, but the rate is still 14.4 because there are many, many, many more births happening in Region 1 when compared to Region 5. The thing that is most notable, and I have 3 points here that I want to make about maternal mortality, one of them being one, after professional review of all of these different cases, it was found that over 40% of these cases were preventable. That means that nearly half of the women who died didn't have to die. Then we need to remember always that perinatal disparities don't stop just with our babies. And for every one Caucasian woman who dies as a result of a maternal birth complication, 4 Black women die. And then when we look at preventability, and when I really looked at this statistic and pulled out this information, it's really, really appalling. When we look at preventability, for white women, they say that 9% of the cases were deemed to be preventable, which means most of the white women who died were going to die anyway. But nearly 60% of the Black women who died of a preventable cause. So what does that say about our society, about our healthcare system, about the way that we are treating women in general, and particularly how are we treating Black women in the hospital and when they're giving birth? And then finally, and the worst news, is that these numbers are rising. And as I was kind of alluding to before, it's important to know that when that initial maternal mortality report was put out in 2018, it looked at deaths up to 42 days after birth. I am currently a member of the Pregnancy Associated Mortality Review Committee, and we are currently reviewing cases out to a year. Because the Centers for Disease Control, the CDC in our country, we look at deaths, when they define maternal mortality, they're looking at deaths out to a year. So we have to understand that that 12 number, that 47 number, as we begin to examine 2017 and 2018 deaths, be very, very clear that the next report that comes out is going to be so appalling to you to see how many women have died over the course of a year when giving birth in the state of Louisiana. It's really frightening. So before we can talk about solutions, and we will, I want to quickly just talk about health inequality, health disparities, health inequity. So the World Health definition of health inequalities are differences in health status or in the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. Health inequities are the unfair and could be reduced by the right mix of governmental policies. And when we think about the disparities and the health inequities that are plaguing the state of Louisiana, and in fact, the United States, be very clear that there are inequalities that are happening because of a distribution of wealth and because of a distribution of policies that do not support the people who need the things the most. We also need to understand that all of this is tied to something that is called implicit bias. Now, we know that bias is inherent. We all have it. No matter your race, your gender, your sexual orientation, your age, we all have some sort of bias. Our individual perceptions of reality are built from personal experiences, media messaging, our rearing, societal norms and stereotypes. This is what happens, what we see on TV, what our families say, what our religions tell us. These things create bias in us, right? It is an unconscious assumption based on these perceptions about another that skews our understanding, unintentionally affecting actions and judgments. So in this country, we have implicit bias that is unintentional mixed with bias that many times is also intentional, right? It is a systematic thing that has been put in place to remove options, to block opportunities from Black and brown people throughout the state throughout the United States. This implicit bias opens us up to prejudice and preconceptions of people, not based on reason or experience, but rather based on these unconscious biases, which then become conscious because some people really buy into and believe these things. So we believe that Black women don't have as much pain, so we treat them less. We don't believe them when they complain about a particular issue, or that they don't know about their bodies, so they don't know what's happening, which would then explain why nearly 60% of the deaths of Black women would be considered preventable. That is like, floors me, as they say, right? Hashtag dead, like out of control. Systematic racism as a social construct continues to plague our nation, continues to plague the state of Louisiana. And until we fix implicit bias, and until we fix, if I go back to health inequities, we will not be able to fix health disparities. Now, I'm going to give us some solutions, and we'll talk a little bit about it. And I'm actually almost done, and then we can have a dialogue. We can open it up to Q&A. But the reality is the foundation of our state, the foundation of our country is based on the control of Black women's bodies. And because everything after that, our entire economic system is based on that, that control becomes necessary. And so it becomes necessary in order to maintain the status quo the way it is. So really what we have to begin to start thinking about is how do we dismantle this entire system and create some entirely new and different ideas in a system that is not open to receiving some of these different things. One of the things that we know when we talk about solutions is that they cannot be one-sided. Our solutions have to come from a systems level. They have to come from providers. There has to be a community level of solution, and there has to be solutions that are connected to the individuals. But what we cannot do is oftentimes when we talk about many solutions, the solution becomes, how do we fix the mom, or how do we give the mom something so that she can be better, rather than fixing the system. And again, until we fix the system, the individuals inside of the system can only do so much. So there has to be this, ground up and top down approach, but that top down is critical. And that's where we keep missing the mark. That's why we 10 years in with the same statistics for 10 years. So disparities are a result of many things. Mostly, as I mentioned, they are a result of inequalities and a distribution of wealth and resources created intentionally via racist policies, the foundation upon which this country and our state were built. Contrary to what many may believe, racism continues to rear its ugly head, and our maternal and child health outcomes are a perfect example. So when we think about system changes, there have to be changes at a hospital level and at a state level where there are policies. Policies are written inside of hospitals that impact outcomes in how people practice, and inside of legislating. And I know that's Michelle's place. That's where she knows the stuff, right? So what kind of things are we looking at that need to be changed? If we're talking about at the state level, there's a conversation right now. I can give you an example. Advanced practice nurses, and y'all take these notes, know these things. Those of you who are involved in systematic policy change, here are the things that need to change that can help change outcomes. Number one, advanced practice nurses, APRNs, whether they are CRNAs, whether they are nurse midwives, whether they are family nurse practitioners. Currently, there is an emergency state right now And so I don't know how long it's going to be in order. The governor signed an emergency stays to where right now, those nurse practitioners do not need what we call a collaborative practice agreement. A collaborative practice agreement means that even if I know what I'm doing, I cannot take care of families without having a physician sign off to say that I am competent and safe and that he or she will be my backup for any complications. The reality is most nurse practitioners don't want to operate outside of their scope. Number one, we want to stay safe. We know what's inside of our scope and not outside of our scope. In addition to that, nurse practitioners largely work independently anyway. They're working in rural communities. They have, I'm telling you, like insider secrets, right? They have a prescription pad in their pockets with the physician's signature on it. They talk to the physician maybe once a month. The physician doesn't follow them day to day and know what's really happening, yet and still this law continues to exist that these nurse practitioners cannot practice independently. If we have nurse practitioners who can practice independently, we can increase the numbers of providers across the state. Right now, we are in a crisis where over 30% of our parishes are, March of Dimes said, they did a report called Nowhere to Go. And over 30% of our parishes do not have adequate obstetrical services, whether that's a midwife, a practitioner, or a physician to provide them care. And I know that there are rural counties, I'm saying counties, I know there are rural parishes across the state where if the nurse practitioner could operate independently, she would hang a shingle and do work. I believe it, I'm confident of this thing because she's from that parish, because she knows people in that parish, but because she can't get any physician backup from anywhere to represent her in that parish, she can't open up a shingle. So we need to change that policy. We need to write policies and change policies around the reimbursement of midwives. Home birth midwives are licensed by the state of Louisiana to give safe, competent care in people's homes. They do not practice outside of their scope. They do not want to have bad outcomes. They are not risk takers. They take care of low risk women. They are licensed by the State Board of Medical Examiners, yet somehow they are not able to bill for Medicaid or private insurance. Problematic. If you are a licensed provider, why can't I qualify for the various spaces where other licensed providers can get reimbursed? There is a lot of conversation right now around doulas and how doulas can support and help families and help improve outcomes, and they can. But doulas are not often affordable by the families who need them the most. So we need policies that support equitable, life-changing income for doulas, not I'm burned out after 3 clients because you're only reimbursing me $250 for 10,000 hours of work, right? I'm exaggerating, but we have to understand that if there is going to be a beneficial way that doulas and perinatal community health workers can move into communities to help families, they must be reimbursed at a rate that makes sense for them. We have to remove financial barriers for prenatal care. Things like, number one, high deductibles. You can have private insurance. You can have a good job and not be able to pay to have a baby because the insurance companies charge you $2,000, $3,000, $6,000, $10,000 deductibles. So now here I can't even get prenatal care because my first visit costs $150 and I don't have it. Literally, there are people who don't go get prenatal care early enough, even with insurance, because there are astronomical deductibles and copays that have to be paid at the visit. In addition to that, providers will not take a mom in until her Medicaid has been approved. Whether that's by force or by what, it should not be allowed. If you accept Medicaid at any point, you should have someone in your office, quite honestly, helping that mom to fill out her Medicaid paperwork so that by the time she leaves the office, the process has already started. Medicaid pays retroactive. So why is it that you will not see a family until her Medicaid is, that should be against the law. We need to advocate for better maternal and paternal leave policies where people are able to stay home with their children. After you have a baby, going back to work at 6 weeks is a crime. We are the only industrialized country in the world that continues to force families to go back to work at 6 weeks postpartum. We need to advocate for hospitals to implement evidence-based practices. Vaginal birth after cesarean section is a safe option for many, many women. It decreases morbidity, it decreases mortality for moms and babies, yet there are physicians and hospitals who will not allow mothers the opportunity to VBAC. There is nothing okay about that, and we need to fight for that sort of thing. We need to fight for people who are being induced at 39 weeks because of coronavirus, because of COVID-19. Right now, they're not letting family members in. They're making people go through all sorts of, in childbirth, you need support. This is one of the reasons why people are traumatized. We need to have emergency policies in place that can help move that out the way when in times of crisis. This is not going to be the last time rather, that something like this is going to happen. So we need to begin thinking forward to when this comes up again. How can we protect birthing people as they're having their babies inside of the hospital? So then we know that we need to have training for providers. We need to have training for providers in implicit bias training. We need to have training for providers about evidence-based care. We need to increase the numbers of nurse midwives and CPMs, certified professional midwives and certified nurse midwives. So just literally the numbers of midwives. How can we do that? We can support legislation that increases the ability for people to get grant funding and scholarships to go into these types of programs. Whenever there's a nursing shortage, money infuses into these states to increase the number of instructors for nursing and to increase the numbers of RNs on the floor. We need to do the same thing for nurse midwives and certified professional midwives so that we can flood the state with more practitioners who are able to provide in community care, which gets me back again to the types of providers. So we're not just talking about obstetricians. We don't need any more maternal fetal medicine doctors. We need individuals who are in community, connected to community, working in community. That includes midwives and perinatal community health practitioners. So what is Sista Midwife Productions doing in order to improve some outcomes across the state? One of the things is something called the Birth Story Project. If you haven't heard about it, shame on me. I would say to please, please, please check it out, thebirthstoryproject.org. Anyone that you know who has given birth across the state of Louisiana is invited to participate in this survey. The goal is to collect data so that we can bring it to legislators, that we can bring it to hospital policymakers and show them what the community is saying about their birth experiences. It captures the names of hospitals, the names of providers. It captures, did you feel respected? Were you a part of your care? Were you given fair options? Were you treated poorly? How was your partner treated? It goes really, really in depth. It does take about 20 minutes per child, but we are asking people to really consider filling it out, because then we can take this data and have hardcore proof and evidence of what people are looking for. So as an example, whenever I'm in different community meetings like insurance providers and things of that nature, and I bring up perinatal community health workers or doulas or midwives, often the question is, well, do people really want that? And I'm like, of course they do, right? And one of the questions on our favorite survey is like, did you have a doula? And then if your answer is no, the next question is, why not? And one of the answers is, I could not afford one. So envision that we have 1,000 people who respond who say that. So then we're showing that there is this need and there is something that people are asking for that is not being made available to them. And then in addition to that, we have a new Healthy Birth initiative that we launched kind of last year, but we're really deep in the training right now. We're almost halfway through the training. It is an initiative that is being supported by the Blue Cross Blue Shield of Louisiana Foundation. So I got to give them a little shout out and thank you. And basically, we knew that we wanted to create something that was going to be sustainable, community-led, and we have called this thing the Healthy Birth Ambassador Training Program. So we are training perinatal community health workers right now in regions 7 and 8, which is the Monroe and Shreveport area. We have 14 women we're training. It is primarily a virtual training right now. We are going to have a skills day. At the end of their training, they will be perinatal community health workers. They will be versed in talking about community health work in terms of perinatal disparities, maternal and infant child health. They will be doulas. They will be childbirth educators. They will be certified breastfeeding specialists. They will be certified in infant loss support. They will be certified as certified breastfeeding specialists. I don't know if I mentioned that. So they will be fully well-rounded. They're also going to have training in leadership development and community health work so that they can really move through the community to bring this message and to help people understand the need. And then the next phase is that we will begin training healthy birth champions. So the ambassadors will be that. They will be waving the flag, this healthy birth flag, right, as ambassadors to bring this message, to identify partners, leaders, and other individuals who want to be trained so that we can train healthy birth champions. And right now we are already under verbal consultation with an organization here in New Orleans, where we're going to be training the first layer of healthy birth champions for another organization, because the idea is that other organizations, that's part of the sustainability. You have an organization, you are sitting in a space, whether it's a Boys and Girls Club, a homeless shelter, a women's organization that, back to work, all of these different spaces, you come across pregnant and parenting women. And someone on your staff needs to have this information so that they can be a better support to families. We have to begin intercepting maternal child health at every avenue, at every single avenue. Like, I often think about pediatricians who do very little and have very little knowledge about postpartum depression and breastfeeding and inter-pregnancy care. And that is the one space where they could maybe put a family nurse practitioner or a women's health nurse practitioner who can actually be, or even just an RN or an LPN who can be having these conversations with moms when she's bringing her baby in for the 1 month checkup and the 3 month checkup and the 6 month checkup. There's nothing happening. We give an immunization, we weigh the baby, we send them on their way. We don't have any conversations. Maybe they do a checklist, right? But they're not doing in-depth anything in depth or anything meaningful around maternal child health. And so that's a missed opportunity. I think about daycare centers, early Head Start centers, where you have a mom coming in there with a 1-year-old, right? She has a 1-year-old, she's 25. Chances are she'll be pregnant again soon. This is an opportunity to interface with the community differently. So every early Head Start in the state should have a healthy birth champion on staff. And so that is the vision that we have, and that's how we're moving this thing forward. I gave you some thoughts on policies. I can tell you that Representative Duplessis and Representative Willard are two people who I know are actively working and pushing forth policies around maternal child health issues. Unfortunately, they had to pull Representative Willard pulled his stuff that was maternal child health related to do more research, and because didn't really have a legislative session, right? Like a regular one. So we're looking forward to what's going to be reintroduced for next year. We also have Senator Barrow and Representative Hilferty. They created the Healthy Moms, Healthy Babies Council. We are done with our first report that I don't think it's public record yet, but look out for that email about that report. There was also a report that was done. This is just information for you. You may want to look for it. There was also a report that was done through Birthmark Doula Collective, where they did a statewide set of focus group conversations to determine the feasibility around doula reimbursement using Medicaid and private insurance. And then we are also almost finished with a report that is going to be a comparative analysis of maternal child health data across the state of Louisiana. One of the things that we found, this is another thing that needs to be changed. One of the things that we found when we moved forward to begin working on deciding where we would do our training, right? We wanted to figure out where were the worst parishes, where were the outcomes collectively the worst. And it was a difficult find. We had to scour for information, website to website, pull down we literally had to pull down from the LDH's website 64 individual PDFs one at a time and print them, to literally sift through them with our eyes. Myself, intern after intern, double checking to figure out that regions 7 and 8 are the regions with the worst overall collective outcomes. That's problematic. I shouldn't have to do that if I am a community organization or even a state organization who may want to institute some work. If there are any grant funders who want to do some work, where are the outcomes the worst? Nobody knows. Nobody knows. So we are putting together this comparative analysis that will also include some solutions around creating a statewide perinatal community health worker training system, which we are taking the lead on right now with the help of the foundation, and we're looking forward to really watching it create some lasting impact for our community. So I am done. Woo! I got through it. And I'll stop sharing.
Okay, thank you so much, Nicole. I'm sure that there are questions, so folks can either type them in the chat box or you can unmute yourself to ask questions. I have a couple myself, but we'll start with other audience members. Okay, well then I will start with my questions. So I remember like when we first started LIPS, trying to get more data about maternal mortality. And the last maternal mortality review that had been conducted was 2012. And then they just now started working on this other one, I guess, what, in 2018 or 2019. So why was there this gap in that effort? Why was there no study of maternal mortality during that time?
So I can't say 100% for sure, but I would lend to that there probably just wasn't funding for it. So the Maternal Mortality Review Committee is funded it's done through the Louisiana Department of Health, Office of Public Health, Bureau of Family Health, right? And they have to have a person who is going to make sure that that everything is pulled, that the data is looked at, that people come. So when we go, we don't get paid, we're volunteering, right? When we go to look at the cases and read them. But the people who review the cases get paid to review the cases. They're part of the maternal child health web of individuals across the state. And they have to have a leader person. Like right now, Dr. Gillespie, who's an obstetrician from Ochsner, she is I don't know what her official title is, but basically she's the head of that committee right now. And so there wasn't, I just think, a priority for funding for it. There's no national mandate around it. And what's happening now is because of the increased awareness around maternal mortality, there's a lot of money that has been thrown at the problem. And so right now there's money at a federal level that states could apply to be able to maintain maternal mortality review committees. And so we have applied for some of that grant funding. I think that we may have gotten some, I don't really know, but I would just assume without knowing that it was mostly funding.
This is Julie. I just want to add that it overlaps with the gender administration and a lack of focus as well. There are people there that could have this responsibility as part of their day-to-day operations. They didn't stop talking about maternal health. They just stopped focusing on it in an accountable way.
Yeah, back to the care, right? We have to care about this issue, and we clearly don't. So if people didn't care, and when Dr. Gee got into her position, she's gone now. And I would assume that the Dr. Phillips, somebody correct me. Well, I assume that she will make sure, but like right now we're in the middle of COVID. So like everything's kind of put on hold for that. But I think that Dr. Gee, she was passionate about this issue about maternal mortality and maternal outcomes as an obstetrician. And so she also was very instrumental in making sure, again, also with, like Julie mentioned, a new administration to make sure that we begin to push this topic forward again.
Great, thank you. I have one, maybe two other questions, but if there are other folks that are on that have questions, you can unmute yourself, or you can raise your hand. Your virtual hand or your physical hand. Okay, Julie has a question.
Yeah, it's about, all the to-dos, which is, really comprehensive and thorough. And I've heard the presentation before, and every time I learn more. And are there efforts to, this may exist in a report of the maternal and child health entity that meets periodically, but those legislative to-dos, do they exist in a document? And is the group working to find, I know there were some bills introduced that got, waylaid by COVID, but is there work to find sponsors for those bills from across the state, or mainly in this region where some of the more active people are working on it? I was just wondering on that legislative angle.
Right. Right now, there is no, so basically different organizations have like a bill watch, and they're looking at different things. We make different recommendations. There is no place where there exists one single list, like these are all of the things that we should be dealing with and talking about collectively. There is not a single body, there is not a single person, there is not a single organization. So we know that right now under COVID, there is this emergency act where nurse practitioners don't need a provider of collaborative practice agreement, right? So right now there is extra buzz and conversation, like what can we do right now to make sure that the collaborative practice agreement doesn't come back, Like, how can we leverage this time to show that we don't need the collaborative practice agreement? So that's happening. The Maternal Child Health Coalition actually put out an email a couple of days ago here in New Orleans asking for individuals who may be interested in helping to write a letter of support. I know that at a national level, American College of Nurse Midwives was really talking to all of the various states to push this legislation or to put the emergency bill in place for it. And so our local ACNM was a part of that, but there's not any space where there is a collective conversation like these are the 10 things that we should be focusing on for maternal child health policy. It does not exist. I think it should. I'm happy to help somebody create one, but that's not the capacity that I have. So I haven't done that. But we will have some of these things in the report that we're producing that should be ready. Our goal is to have it launch out with the first graduating class of Healthy Birth Ambassadors, which will be in August. So look forward then.
That's a good question. Thanks, Julie. Yeah, I mean, that's something that I think LIFT would be interested in working on is pulling together a list of proposed policies that we could address some of these. And I also did an advocacy and sort of legislative policy training with the Healthy Birth Ambassadors. And I was very pleased to find out that several of them already had experience lobbying and advocating and talking to legislators. So I think that program offers a really, really great opportunity to have one person embedded in each of these public health regions that can sit down and talk to legislators in that region about what's going on, what the outcomes look like, and what, the policy proposals are, in the works or being proposed to address some of these issues. And, I think that it would be great, if we could build up some leadership among legislators in other parts of the state so that it's not just Orleans Parish that is standing up and doing something about this. So I had another question, particularly about Representative Willard's proposal that I think aimed to address the reimbursement issue with midwives. So how would the policy that he introduced this session have or have not addressed the real problem? And then what are some things that can be done to improve that policy? I would imagine that it's something that he's going to want to try to bring back in the next session.
So one of the things that he and I talked about was really making sure that his language in definitioning the two different types of midwives becomes more clear. One of the problems that we often find is that there is not a cohesiveness around nurse midwives and professional midwives, which are the home birth midwives, in terms of policy. And it's mostly because they do operate under different types of legislation. So right now, the nurse midwives have to have a collaborative practice agreement. The home birth certified professional midwives do not. The home birth certified professional midwives do not get to be reimbursed. So his policy did say that we should reimburse them. Another piece that he was very good about was talking about the percentages of how much midwives are reimbursed. So you can have a physician and a nurse midwife at the same hospital do the exact same birth, and they will be reimbursed at different rates. Nurse midwives are reimbursed at a lower rate than a physician is for the same exact birth. I get that a C-section might be reimbursed more. I get if this person is high risk that you're reimbursed more, but they will get reimbursed different amounts for the same exact birth. So that's problematic, and there was some languaging that talked about that. The one thing that I mentioned to him that wasn't a part of it at all, a lot of his wording was around there would be reimbursement after all deductibles are met. And it is new for me to know because I have one child. I qualified for Medicaid at the time. And so I didn't pay for my birth. I was very blessed. I didn't have to deal with co-pays and insurance. And so I've been working with a few moms recently. And after this happened, I went to Facebook and I was like, hey, like, what is your experience with this? And the comments that were coming back, I was floored. that there are people who literally are not getting care because their visits deductibles are $100 and $150, and that they have a $4,000 deductible before they can not have to pay that. And it's like, I mean, I don't know, some of y'all might have it, everybody don't have it, right? To really do that type of prenatal care. And so I talked to him about that, and that I don't know how that can be shifted or helped, but it's critical. I spoke with a young woman very recently. I was recommending to her a provider that I knew would be just based on her needs and how she was as a young Black woman. I said, here's who you should go see. And she was like, oh, I tried, but I couldn't go see that person because she's a young woman who's on her mother's insurance. And her mother's insurance, this provider is out of network. So $150. And so then there's the dilemma, okay, so do I drop off my mother's insurance and apply for Medicaid? If I apply for Medicaid at the wrong time and I say the wrong thing, then I'll get denied, then I don't have my mother's insurance, and I know a woman who I was working with who has insurance through her job. She is a daycare worker. So you all know, as a daycare worker, she is not making no whole lot of money. And you know that her insurance policy can't be that good. Yet and still, she was denied Medicaid for her birth because they said she already had insurance. And so how do I go to my prenatal care appointments? I can't afford them. Ashner literally calling her on the phone like a bill collector in the middle of her pregnancy, harassing her about payment for labs, for ultrasounds. It's problematic. So we have to make sure that whatever language we put, when it comes to maternity care, we've got to make it more accessible. And it can't be about lining pockets, which unfortunately so much becomes about lining pockets. And so we have policies in place that don't support the care. It just supports the financing of the people who have deep pockets.
Well, I think it's really interesting as, when we think about, the gender pay gap, so I'm going to kind of try to merge these two things together that, we've structured this, this system of reimbursement so that, the women who are delivering babies, and in a lot of cases, Black women who are delivering babies aren't going to be paid as much as, the white men OBGYNs or the white lady OBGYNs. So I think this, you've explained to me like how important this is, but I also just think that it's, it's a structural system where we undervalue women's work,
Yeah, across the board.
Yeah. So Kylie Mayfield has a question.
Hi, Nicole. I appreciate your presentation, and I wanted to comment on like policies, a group about policy. So I work with MBEC, and I also work with the MCH Coalition, and I kind of inform them of policies and stuff that like MBEC is looking at and watching. And I would love to connect with you about more policies. And MBEC, we're working on a document, and we're still in the process of looking at policies or gaps that need to be filled with policies to distribute for next year, for next legislative session. So I would love to connect with you for like the MCH Coalition and for what MBEC is doing, because we have a lot of the same interest, and even with Michelle touching on like the pay gap. So that's something that we're standing on, and I completely understand like how there are different policies that are getting missed, because I just learned about House Bill 344 last week in a meeting, and that bill is about solitary confinement, solitary
and pregnancy.
Yeah, so I just found out about that last week. So it's very important that everyone shares the policies that we're all looking at, because all of these policies impact all of our organizations and the community as a whole. So I just, I copied your email address, and I just wanted to say I will be reaching out to you about that. So like,
okay, and I'm connected to the MCH Coalition. I'm a part of that too. So
okay,
yeah.
Okay, so if you see in the emails like certain policies that they are mentioning, I'm the one that's informing them of the policies.
I see. Okay, right on.
So yeah. Okay.
And nice to meet you.
Yes, nice to meet you as well.
Yay, I love Zoom connections. Are there any other questions that folks have? All right. Well, I mean, I could sit here and pick your brain for the rest of the day, Nicole, but
I'm not gonna let you.
But you are very busy, and you have already given us so much of your time, and I really am very grateful that that you were able to do this today. I think that it's been really helpful and informative. We did record it, so we will put the link up or out to everybody who joined. And we've been uploading these to our YouTube channel at Lift Louisiana as well, so people can go there and find, review them. You can share them with people that maybe couldn't join today.